First, I wish to introduce my cordial thanks to Badr, my friend Badr, for his kind invitation to this outstanding meeting in Cairo. I'm going to talk about the benign paroxysmal positional vertigo, the new insights on it. Of course, we must begin with the otoconia because these are the sediments, otoliths that travel within the fluids of the inner ear from the side of utricule towards the semicircular canals, which create a kind of stimulation on the hair cells to stimulate the vertigo feeling. These are calcite-based nanocomponents containing calcite crystals. Their size is about 10 micrometer, and calcium is required for mineralization for the maintenance and its turnover. When they degenerate, they can be written and they can easily crop from the other crystals, I mean the otoliths, and they move towards the semicircular canals. They generally migrate from utriculus to semicircular canal. These are the free-floating particles, so due to the head movements, their motion within the endolymph will eventually create a stimulation over the hair cells. What is the pathophysiology in BPPV? In vertical canals, with the movement of the endolymph, the kinocilia moves away from the utriculus. But in the horizontal canal, kinocilia moves towards the utriculus. So, within the vertical canals and the horizontal canals, the action of the nystagmus will be different from each other. We must know the Ewald's laws before beginning to understand for benign paroxysmal positional vertigo. The first Ewald's law is vestibular evoked eye movements occur in the plane of the canal being stimulated. And the second law is the stimulatory response is stronger than the inhibitory one. So, leads to the ear excites and logs in ear inhibits. The third law is the movement of stereocilia. The movement is towards the kinocilium. So this means that there is depolarization equal to stimulation. The movement of stereocilia away from the kinocilium is called as hyperpolarization, and it is the inhibition. So, what happens due to the Ewald's law 1? The eye movements are dependent on the stimulated semicircular canal. For example, now this shows the posterior semicircular canal. For posterior canal, we thought that we were used to know only the posterior canal canalitiasis, but now we are aware that there is a canalitiasis of the short arm in the position D, non-ampullary end and crus communis in E, and there is cupulolithiasis of the canal side in B, and utricular side in C. Let's see how all these works. And this diagram shows the location of the otoliths, how do they move when distal pike is presented. Now, let's proceed with the clinical terms. The posterior canal, canalithiasis, for example, this is the right side, and distal pike, I'll show you how distal pike maneuver is carried out. And we see the torsional nystagmus in supine position, and the reverse nystagmus when the patient is up, sitting position, because the canaliths, otoliths go back when the body is upright. And in this situation, we perform a place maneuver. In a place maneuver, the patient gets in supine position with head hanging on the side of the affected side, and then slowly turns the head on the opposite side until the face is directed to the ground line. For the canalithiasis of short arm, there is no nystagmus in supine position, but a vertical nystagmus in torsional to right. You can experience and remember your patients doesn't experience any kind of dizziness in the supine position, but screaming when they sit. So we perform here the demi-Semon maneuver. This is the demi-Semon maneuver. In canalithiasis of the non-ampullary end, there will be downbeating torsional nystagmus. This is simulating the anterior canal, because this is very close to the anterior canal. And in the sitting position, the same nystagmus continues. So we have to distinguish this with the real anterior canal nystagmus, because for the posterior canal, the torsional is indifferent from the posterior one. In canalithiasis of non-ampullary end, we perform the fast Jacovino and fast liberatory maneuver. This movie is taken from Anita Bandari. In posterior canal, canalithiasis of the canal side, cupulolithiasis of the canal side, we perform Semon plus maneuver. There is upbeating torsional nystagmus, and within the sitting position, it is reversed. There is no latency in this situation. In uticular side, in supine position, there is no nystagmus, but in the sitting position, there is upbeating torsional. And we perform the quick laboratory maneuver. For horizontal canal, again, we understood that there are more positions of the otoliths in the horizontal canal. In the horizontal canal canalithiasis of the long arm, of course, we should expect geotropic nystagmus, geotropic horizontal nystagmus. The stronger nystagmus, if we observe the horizontal nystagmus in both sides, the stronger nystagmus shows the side of the affected ear. This is lateral supine test that we check if there is horizontal canal involvement. So we perform either geotropic euphony or barbecue maneuver to treat this case, to reposition the canaliths towards back to the utricle. You will see there are two different types of euphony maneuvers. One for geotropic. In the geotropic one, the nose touches to the bed, but within the apogeotropic, you will see within the next slide. And I will make it a bit. This will make about 270 degrees of body movement on its axis. In cupulolithiasis, there will be apogeotropic nystagmus. The most critical point is the weaker nystagmus. If there are bilateral, the weaker nystagmus side shows the side of the involvement. So this is the apogeotropic. And as I mentioned, within the apogeotropic involvement, we do apogeotropic euphony. And in contrast to the geotropic one, the nose shows the ceiling after lateral spine, like this. And in some cases of horizontal canalithiasis that's close to ampulla, we can also get benefit of Zuma maneuver. This is quite simple but very effective. In case of having similar amplitudes of horizontal nystagmus bilaterally, then we need to differentiate which side is affected. So we have to perform bow and lean test. These are the figures that shows bow and lean tests for canalithiasis. That is, in bow, the nystagmus beats towards the affected ear, and in lean, beats away from the affected ear. But for apogeotropic, it is vice versa. For vertical nystagmus, of course, we can distinguish it from the posterior canal variant, but if this nystagmus persists, we need to, it is necessary, an obligation to obtain an MRI, because this can easily be misdiagnosed with an intracranial pathology. So what happens following? One, we have a successful maneuver with no remaining nystagmus. We can have a successful maneuver but remaining dizziness. We may have successful maneuver completely resolved, or we may have remaining otoliths in the canal. So this also causes residual dizziness. We have a quite recent publication with Herman Kigma, Leonardo Manzari, and Michel Lacour, criticizing the residual dizziness after BPPV management, and we underlined the exploring pathophysiology and treatment beyond canalith reposition maneuvers. And this can be summarized as the vestibular syndrome ameliorates over time in a process described in the literature as vestibular compensation. The dizziness feeling can be accepted as a symptom feeling that occurs until strong asymmetry in the spontaneous firing discharge of the vestibular neurons disappears. And the recovery of the dynamic symptoms implies the whole brain, which uses sensory substitution process and elaborates new behavioral strategies to mimic the loss of vestibular neurons. So the remaining otoliths in the canal for residual dizziness is due to, the dizziness is primarily due to the non-repositioned otoliths in the canal causing symptoms. So we need repeated CRM, and the background picture is more prominent in such cases. We can also ask ourselves if it is necessary to add any medical treatment. When we go and focus on the pathophysiology, the mechanisms of action of beta-histine as being a histamine-like drug working as both partial H1 receptor and more potent in H3 receptor antagonist can be helpful. And before finalizing my speech, I wish to invite you all to Vertigo Academy International meeting in April in Budapest, and also to Istanbul for the World Congress in 2026. Thank you very much.
Wonderful presentation and illustrations. I think we can take one question. So yes, please, Doctor.
I'm so sorry that I cannot hear you. Can you come closer, or is there any microphone for you?
Yes, please.
Yes, ma'am.
Thank you very much for your nice presentation. Actually, I did some research on the residual dizziness in post-BPV after successful maneuver, and we found that there is otolith dysfunction. This is the main cause. What's your opinion? What's your management?
Can you tell the cause you find out?
Otolith dysfunction. Otolith dysfunction.
Otolith dysfunction.
Yeah.
Yeah, this is another argument to be discussed and now becoming popular. We cannot understand how do the otoliths behave when they go to the utricule, and how do they arrange themselves within the otolith, within the utricule, and it's a big question mark to be
Still question
distinguished.
mark.
Yeah.
Okay. Thank you.
Thank you.